So I'm Josh, one of the R2s, far less distinguished than Dr. So, but that's okay. That's okay. So I'm already a little over time with the presentation, so this will be the fastest review of urinary biomarkers you will ever see on this side of the Wild West. So, as everyone knows, cystoscopy and upper tract imaging form the basis of your workup for hematuria, but the guidelines often recommend using urine cytology as a useful adjunct. And it's relevant because cystoscopy, number one, carries a burden of discomfort as well as the economic component, especially in the context of the non-muscle invasive setting, where the rate of recurrence is quite high. And so to be able to adopt some kind of urinary test that could serve to reduce the frequency of your cystoscopy can help to mitigate some of those issues. Which brings us to urinary biomarkers. So these are certain substances or characteristics that can be detected in urine, potentially indicating the presence or absence of bladder cancer in patients. And so the two main settings in which this would be useful is obviously someone that arrives to your doorstep with undifferentiated hematuria that you need to work up for cancer, or in patients with a prior history of cancer that need to be undergoing surveillance. And so some of the ways that this can manifest is in whole tumor cells, certain proteins, gene expression, epigenetics, as well as cell-free DNA. So what makes a good test? Well, obviously the test characteristics are important in the sense that your sensitivity and your negative predictive value help to identify patients who can potentially forego further cystoscopy or workup, whereas your specificity and your positive predictive value help rule in disease. So especially in cases where otherwise your upper tract imaging or cystoscopy appears negative. Obviously, we care about whether tests are cost effective, whether they're practical and easy to use, and of course, in all of these cases, with non-invasive tests, they're safe and tolerable for patients. So that brings us to urine cytology. So we already have this guideline recommended test. So why has it or could it even replace cystoscopy in this setting? Well, let's talk a little bit about how urine cytology came to be. So Papanicolaou in 1945 described this method of aspirating urine and fixing it in alcohol, spinning it down, removing the supernatant, and smearing the remaining sediment on slides, and identified 27 cases of malignancy, of which 89% were actually confirmed on biopsy or clinically. And this was after he recognized that the cancer cells of the uterus were exfoliated and could be identified in other types of smears. And yes, it's the same Papanicolaou as a pap smear. Now, things are a bit different these days. So on the left is just patient instructions from Life Labs. But what we know now is that peeing out the urine yourself is pretty much the same as trying to aspirate or wash the bladder. So that's obviously something which is a bit more practical for patients. And nowadays we use something called Cytolite, which is a methanol-based preservative solution, which is optimized for preserving the cytology samples. So you pee in a cup and you bring it into the lab, but what happens when you're in the lab? Well, historically, pathologists kind of had very subjective ways of reporting the findings. So usually you'd get some degree of a result from anywhere between negative to atypical appearing to positive. But the thing is, there wasn't actually a standardized system for which they were making these decisions. And so the PARA system, which was created in 2016, aimed to standardize the reporting and the findings between pathologists and urologists. And it composed of these 7 main categories: the non-diagnostic and the other lesions, and negative, atypical, suspicious for high grade, positive for high grade, as well as low grade urothelial neoplasms. This is a flow chart, sort of in the mind of the pathologist, of how they made those decisions. But the issue is that more often than not, their samples would end up going in this category. In fact, as much as 31% of samples were still labeled as atypical. And as any of the urologists here know, an atypical cytology specimen doesn't really give you much benefit because you can't say it's negative, but you also wouldn't necessarily go looking through the books if your sample was atypical. And so they devised a second version of this, the TPS 2.0 in 2022. And the main concerns that they had were, of course, to reduce the rates of those gray zone diagnoses. But the other thing is, if you recall here, the sort of pathway for low-grade disease was the presence of these fibrovascular cores. But the issue is that there was a misconception that having a fibrovascular core automatically labeled you as low grade, which is not true. And so there was often some miscommunication from that perspective. And so this is the now TPS 2.0 flowchart, and I won't go into the details of it, but the things that are of most relevance to us are negative, atypical, suspicious, and high grade. With the publication of the TPS 2.0, this was a table that was also presented in that, and what you'll notice is that on the right-hand side, they list the general ranges for high-grade malignancy that are associated with each category. And what we'll see in this meta-analysis is that the reported high-grade malignancy rates are actually pretty concordant with the ranges that were initially provided by the TPS 2.0. Notably, the overall sensitivity across these 28 studies was only 0.669. And this is a prevailing issue that we know of cytology. These are a couple of real performance characteristic studies, one in 2019, in working out patients with both gross and microscopic hematuria. And again, we see that the sensitivity is quite poor, only 40%. However, we know that the specificity of cytology is quite good. Here it's 96%. Now you may look at the negative predictive value and think, oh, you know what, 95% is quite good, but you have to consider that in this diagnostic setting, with gross and microscopic hematuria patients, your actual pre-test probability for someone walking into your door undifferentiated is only probably ranging between 1 to 5%. So if someone were to come in and I were to label every single one of you negative, that would be the same as a negative predictive value of 95%. So it doesn't really tell you very much. This is just another example. Here they actually report specificity as high as 99%. So how does this manifest in the guidelines? Well, as we mentioned, cytology is recommended as an adjunct, and it's useful in the sense that it can help rule in occult disease, which we'll touch on briefly here. High-risk patients are recommended to have cytology up to every 3 to 4 months for the first 2 years, and then kind of space out as you progress through your surveillance, which makes sense because you expect that the prevalence of the disease is quite high, so there's a higher yield for you to do cytology to make sure you're not missing something. They also recommended in the intermediate risk group, but you have to consider that you can have a patient who comes into your office with multifocal low-grade disease, therefore falling into this category, but your likelihood for them progressing to a high-grade tumor is still quite low. So some urologists may choose that the diagnostic yield of doing cytology this often, as per the guidelines, is not necessarily worth it. What we also know is that the presence of urine cytology being positive can also predict CIS, or occult CIS. So this was a study in 2009 in which 173 patients had TURBTs and random bladder biopsies. And what they found is that 59% of the high-risk patients who had a normal appearing cysto had CIS on random bladder biopsy, and it was positively associated with having a positive cytology result. And so this goes back to the idea that patients with a positive urine cytology with that pretty high specificity gives you the idea that there's maybe some degree of occult disease because your rate of false positives is expected to be quite low. And so the CUA recommends that if you have a positive cytology, but your other workup is negative, it means you should look harder. And so that could look like doing random bladder biopsies, doing enhanced cysto, or investigating your prostatic urethra. Something else that we know is that cytology suffers from variability between observers. So this was a study in 2017 where 4 pathologists analyzed 357 specimens, and only 2/3 of the specimens actually had agreement between pathologists. And in fact, up to 12% of the comparisons differed by more than 2 categories. So what that would look like is that someone could label a specimen negative and the other person would label it suspicious for high-grade carcinoma. And obviously your treatment pathway, depending on those 2 differences, is significant. And so we've discussed that some of the issues with cytology are primarily that of inter-observer variability, the fact that your reporting could be standardized, the test performance could use some work, and you still need a pathologist to interpret everything. So with anything these days, how can AI help to solve that issue? Well, this is a study by Wu in 2024 in which they trained a system called the Precision Urine Cytology AI Solution across over 2,000 patients. They validated it across 2,000 retrospective patients in a cohort, as well as 400 prospective patients. And all patients were undergoing cytology for either screening or surveillance. This is a table from the study. On the left-hand side, some of those acronyms are just representing different hospital cohorts, so their exact acronyms are not important here. But you'll see that across the retrospective cohorts, they reported that this AI system actually had a sensitivity ranging between 0.922 and 1, which is significantly better than what we've seen previously with a normal urine cytology. And the test characteristics are actually still preserved even in the prospective cohorts. They also compared their AI system to a few other tests, namely your typical cytology, but also something called FISH, or fluorescence in situ hybridization, which we'll talk about in just a moment here. But you'll see that across the board, the sensitivity, despite grade or stage in the diagnostic setting, was better than all of the other tests. So we're cystoscopies. And so I kind of like to think of cytology as sort of your old faithful. So you know that your sensitivity here is quite poor, at least in the normal setting, but your specificity is high. And so with the low false positive rate, you can rule in occult disease. Now, we know that it's an in-house test, it's relatively economic, but it still requires a pathologist to interpret it, and it suffers from issues like inter-observer variability. And again, it's a non-invasive test. Now, something which is quite complementary to it is Eurovision. So Eurovision, or FISH, which is fluorescence in situ hybridization, is the multicolor, multi-target assay, which uses fluorescently labeled DNA probes that target sequences on chromosomes 3, 7, 9, and 17. And these have been associated with urothelial carcinoma. And so they will stain these samples under a fluorescence microscope. And these are the 4 probes that are of relevance. What you'll notice here is the gold one is specific to 9p21. And this is relevant in just a moment here. These are some examples of specimens. Down here in the bottom is an example of a normal appearing Eurovision study here. You expect to have 2 chromosome copies at each of those different targets of each color, which we can see represented here. On the other hand, on the left, this is a cell which seems to have 6 copies of red and 6 copies of green. And so what we define as a positive cell in a FISH study is if you have 3+ copies of a chromosome, so that would be 3 colors or more, and if you have the loss of your 9p21 or the gold marker. And so we can see that across all of these different labeled cells here. And so what you do is you look through your entire slide, and if you can find 4 or more cells like that, your overall specimen is considered a positive result. What we see here is just some of the examples of the performance characteristics in the multi-center prospective trial. It seems that the sensitivity is maybe a little bit better than cytology, but your negative predictive value is ever so slightly better, if not similar. But you lose some of your specificity and positive predictive value over cytology. Interestingly, they've also demonstrated that Eurovision could predict your treatment response to BCG. So this is a study by Lotan in 2019 in which they studied 150 patients undergoing BCG for non-muscle invasive disease. And what they showed is that your risk for an event, which could be a recurrence or a progression at 9 months, was significantly worse if at any point, such as your first BCG, your 6th BCG, or at your 3-month cysto, if you had a positive Eurovision result. So Eurovision, it's sort of like colorful cytology. The test characteristics are different, but not necessarily better across the board. It's actually quite expensive. So what I can see is that the assays can cost upwards of $800, and that's not including the interpretation costs. It's, again, a non-invasive study, but overall, there's no evidence of it being available in BC or Canada, as far as I can tell. Mhm. So we've talked a little bit about cytology and Eurovision, but why don't we walk down this proverbial yellow brick road and see what lays on the horizon for us? Which brings us to single protein monoclonal antibody tests. So on the left is something called BTA STAT, which is a monoclonal antibody test specifically testing for bladder tumor antigen, which is a complement factor related protein which helps to protect cells from lysis. And then on the right is NMP22 bladder check, which detects nuclear matrix protein 22, functions in DNA replication and RNA synthesis. Both of these were found to be overexpressed in urothelial carcinoma. But the test characteristics are just not very impressive. So you'll see here that your sensitivity maybe is marginally better than cytology, but you lose all your specificity, and likewise for NMP22. And so both of these have kind of gone the way of the wind, and we rarely see them in use these days. Sorry, who are we talking about here? It's not really useful. To be fair, it's cheap, it's foolproof, but it doesn't really lend very much information to you. So why don't we talk about what's going on these days? So in particular, tests that are looking at gene expression or epigenetics. This is a non-comprehensive list, but some of the things that I'll touch on today. The first test is called Assure MDX, which they have themselves labeled on their box as a liquid biopsy. And so it's an assay which detects your mutation status of 3 genes, FGFR3, TERT, and HRAS, as well as your methylation status of OTX1, 1CUT2, and TWIST1. And DNA methylation is relevant in the sense that your cancer cells are able to hyper or hypomethylate certain genes. If you hypermethylate things like anti-tumor related genes, it downregulates them and can silence those genes. And on the other hand, if you hypomethylate certain oncogenes, it can help activate or lead to chromosomal instability. Overall, you mail in your urine to a central laboratory and they spit out a result for you. This is just a table from their validation study from a retrospective cohort, and you'll see here that they actually represent a sensitivity which is quite a bit higher than what we've seen so far. So across all patients with gross or microscopic hematuria, sensitivity was as high as 95.5%. The issue is that this is just a validation study. It has not been demonstrated in any kind of interventional study. We have not seen it actually being used to reduce the rate of cystoscopy. We don't actually know if the outcomes are different if you defer cystoscopy with this test. And you'll see this is a prevailing theme in a lot of these biomarkers. This is another example. This is called Bladder EpiCheck. This is an assay which detects your methylation pattern across 15 different biomarkers, which are proprietary, so we don't know the exact locations or the genes that they test for. But this is an example of the program on the left here, where they use RT-PCR and measure the relative fluorescence over each cycle. Again, completely just a validation study. To be fair, this is a prospective trial, but they seem to demonstrate a specificity which is quite high. Your negative predictive value, again, is 95%, but we know that in the diagnostic setting, it's not as useful. Interestingly, however, this was actually done in patients who were pending cysto for surveillance. So you expect that your prevalence of disease is actually quite a bit higher. And if you excluded all your TA low-grade recurrences, they actually reported a negative predictive value as high as 99.3%. Promising, but again, no prospective interventional trial to assess the safety of using this test over cystoscopy. So why don't I start talking about some of the other tests? This is called CX Bladder, which I've named the Kiwi box because it comes from New Zealand. It's a suite of tests that are used for different settings. CX Bladder Triage is specific to the diagnostic setting. So someone rolls into your door with undifferentiated hematuria. And it's an assay looking at genes, namely MDK, HOXA13, CDC2, IGF-BP5, and CXCR2. And they also incorporate 4 phenotypic characteristics of age, sex, smoking history, and hematuria history. They put it into their proprietary algorithm and give you a score between 0 and 10. and a cutoff of 4 for positive. This was actually demonstrated in the STRATA trial. This was a multi-center prospective trial comparing CX bladder triage to your standard of care and workup of microscopic hematuria. And the process for how patients were stratified is a bit confusing, so I'll try to go over it on the table here. So patients were first risk categorized. So if you had 3 to 29 RBCs per high power field and up to 10 pack years, you were considered lower risk. On the other hand, anyone else was considered not lower risk. If you were in the not low risk group, you would still get CX bladder testing, but you would not be told your results and you would go straight to standard of care. On the other hand, if you were lower risk, you were randomized to either a control arm in which the same thing happened and you would get your test but would not have the result reported, or the test arm in which you would actually be told your result. And this was relevant because if you tested negative, you would actually be recommended to skip your cystoscopy. Ultimately, it was still the patient's decision on whether or not they wanted to do that. Primary objective here was a reduction in the number of cystoscopy procedures. And what they showed is that across 390 patients, 82% of the not lower risk group had a cystoscopy, and in the lower risk group, the standard of care, or the control arm, 67% had a cysto, whereas the test arm, 27% had a cysto. So an absolute reduction of 40% in the cystoscopy rate across those two arms. The thing is, they didn't technically use a primary objective of outcomes, but they have reported in their study that for the 57 lower risk patients that were negative and chose to not have cysto, there was some follow-up data available in 48 of them, and 29 of them also had a repeat CX bladder triage test done. And there was a single patient 13 months later who had a then positive CX bladder triage test and then got a cysto which showed a single high-grade TA tumor. There was no other evidence of missed tumors. Fair. Now, as far as the test characteristics go, in the low-risk group, they reported a sensitivity and negative predictive value of as high as 100% across the board. But again, this is with limited follow-up data. And the overall primary objective was not in the context of your actual oncologic outcomes for this study. Now, another test in the suite is called CX bladder monitor, and this is specific to the surveillance setting, which uses the same gene panel and includes characteristics of your previous tumor status as well as time since your previous tumor. Again, the algorithm gave you a score from 0 to 10 with a cutoff of 3.5 this time for a positive result. And this is a study by Lee in 2023, which 92 patients, all with a history of non-muscle invasive disease and due for surveillance cysto, had CX monitor done. And if it was negative, they would skip cysto. And what they showed is that in the 24 patients who were positive, 9 of those, or 37.5%, did have a positive cysto necessitating biopsy. You'll see some of the results that they found on the biopsies. And of the 66 patients who were negative, there were 52 who had a follow-up cysto, and none of them ended up having cysto findings requiring biopsy. Obviously, the sample size is quite low, but it does lend some potential thought into whether or not it would be safe to use in the surveillance setting as well. Here, they also report a sensitivity and negative predictive value of 100% each. But so far, we haven't had an interventional trial focusing on outcomes. So why don't we talk about Expert? This is sort of like a console. It's a proprietary system that does all of the testing itself. You just have to plug in your cartridge with urine into the system. It's a bit plug and play. This is another assay measuring these 5 mRNAs, which are overexpressed in urothelial carcinoma. And as mentioned, the Gene Expert system automates the entire RT-PCR process. This is the cartridge that they use. So urine is put into this little chamber, and then you plug it in the system. They do fluorescence in cycles, and you can see it increase exponentially with each cycle. And the system will automatically give you either a negative or a positive result. And what they've shown is that across the board here, Expert seems to be slightly better in terms of sensitivity and negative predictive value compared to both Eurovision and cytology, but at a loss for your positive predictive value and your specificity. And they've also tested it in the surveillance setting. Similar numbers, but you'll notice that the sensitivity and the negative predictive value are a little bit worse, which is not surprising given your prevalence of disease is going to be increased. But it was used in this trial, the DeBlaca 15 trial. This was a multi-center randomized non-inferiority trial comparing expert to standard of care in patients with previous high-grade non-muscle invasive disease. So if you were in the control group, you had standard of care, which was cysto every 4 months, up to 24 months. And then the intervention group would have expert done instead. If at any point your expert was positive, you would then undergo a follow-up cysto. They also included cystos at the 12 and 24-month marks for safety purposes. And the primary objective here was recurrence-free survival, with a recurrence being defined as a high-grade non-muscle invasive disease, muscle invasion, or metastasis. And so what they showed is that the detection of recurrence was not inferior to control. You see here, the Kaplan-Meier curves are pretty much converging. There was a similar number of recurrences found in each arm, and they also note that of the intervention arm, 13 individuals seemed to have a positive expert test even before cysto found anything. There was obviously a significant decrease in the number of cystoscopies that had to be done in the intervention arm. And they do note that there were a total of 2 high-grade recurrences, which were missed entirely by experts and only found in the intervention arm. Now, the issue with the study is that they do report their overall rate or expected rate of recurrence was quite a bit lower than what they were anticipating. And so what that means is when we're looking at the reported test characteristics, like their negative predictive value of 99%, it's going to be artificially inflated because it doesn't represent your standard population. And likewise, you can consider the fact that with a lower rate of recurrence, a trial that looks at your detection of recurrence is going to automatically look better if patients generally don't recur in the first place. Again, going into that idea that if I were to call everyone negative here today, chances are I'll be pretty right. So that brings us to the end of our genes and methylation talk here. So there's been some studies ranging from a single interventional trial to various prospective and retrospective validation studies. But the point is, it seems like the test characteristics of these tests are quite good, but we're just not there yet in terms of the evidence to suggest that it's absolutely safe and we can definitely replace cystoscopy in all settings with this. They are quite expensive. So the expert system, only for 2 cartridges, costs $10,000, and each test is 250 euros on top of that. You may need to ship your urine in. You could use an in-house system. And again, it's a non-invasive test. Now, with respect to the interventional trials, there was another trial just recently called the Eurofollow trial. This was also a multi-center randomized controlled trial. And what they did was they compared a marker-based surveillance regimen compared to standard of care, specifically in patients with low or intermediate risk non-muscle invasive disease. Now, it was interesting because their regimen was pretty unique. It included an ultrasound, cytology, NMP22, didn't think you would hear this one again, and Eurovision. And their primary objectives here were the rate of detection as well as the progression to a high-impact tumor, which was defined as either a high-grade TA, CIS, or T1+. And so the arms were either you get the marker-based regimen every 6 months or so, up to 3 years, or standard of care, which was not specified, basically at the discretion of the urologist. And what they found is that across 214 patients, all of the high-impact tumors appeared to be detected across both arms. And from a statistical perspective, there was no difference in time to tumor recurrence. However, you can see that in the Kaplan-Meier curves, as we're approaching the 3-year mark, there does appear to be some level of maybe divergence, and the p-value is borderline. It's 0.056. Not statistically significant, but you do wonder if the curves will continue to diverge further with further follow-up. Nevertheless, the marker-based regimen missed 5 low-grade tumors, and not surprisingly, there was a significant decrease in the number of cystoscopies that needed to be done. Obviously, the issue of the study being Could it potentially be a positive study in the sense that there's a difference if we were to further the follow-up? And also the regimen that they used was a little bit unusual. It's not really using the contemporary tests that we have these days. But what they did do was they also tested some of those more contemporary tests. These were not used in the actual decision on whether to do cysto or not, but they used it more as a simulation and to get a sense of their performance characteristics. And you'll see here, expert and bladder EpiCheck were specifically noted by the study as having similar levels of performance to the algorithm. And so their conclusion, or what they extrapolated, is that since our regimen was safe, these tests might also be safe. They also note that all the high impact tumors that were tested by both EpiCheck and expert were identified. So where does that lead us in terms of the guidelines these days? Well, the AUA guidelines most recently have updated that in appropriately counseled intermediate risk patients who would like to avoid cysto, you can offer these urine-based tumor markers to help facilitate that decision. You may wonder why they haven't recommended it in the low risk or the high risk group. And with the low risk, we know that the chance of them actually having cancer is low. So your diagnostic yield for doing these tests that have a range of different sensitivities is also going to be low and likely not cost effective. And on the other hand, in high-risk patients, the overall incidence of the disease is going to be quite high, and there just isn't enough prospective evidence to demonstrate actual safety or efficacy in using these types of tests instead of cystoscopy in this population. They also actually have this table of different tests in the AUA guidelines, some of the ones that we've talked about today. And in the surveillance setting, they do not recommend urinary biomarkers at this time, likely for the same reasons that were discussed for high-risk patients, but your prevalence of disease is so high, you wonder still if using these tests to replace cysto is safe, because our evidence is still limited. So where are we these days? There are some things that are always on the horizon. One thing that is in production right now is called Oncuria, which is a multiplex assay detecting 10 different proteins listed right here. And they integrate it with your demographic data and then put it into their algorithm, as all these tests do, and spit out a positive or a negative result. And in their validation trial across both microscopic and gross hematuria workup, they actually report pretty good specificity and sensitivity of 93%. But this is not yet FDA approved yet, so probably won't be for a while until you start seeing it in practice. And even then, we're here in Canada, and we don't have any of these tests anyways. Now, urinary tumor DNA is something which is also generating quite a lot of buzz these days. So many people here already know of circulating tumor DNA, but we know that some of the DNA can also be filtered through your glomeruli. And of course, if you have active tumors in your GU tract, it can be shed directly from tumors as well. And so if you were to isolate this DNA, you can assess for things like mutations, copy number changes, your methylation status, histone modifications, all the sort of epigenetic factors here. And the overall functions are the same as what we've seen so far. It can help detect new diagnoses of cancer and help survey different disease processes. But there's also some implications here on whether it can help predict treatment or prognosis, tell you about the biology of the tumor, or even rule in different therapies for you, which we'll talk about. UroAmp is just one such assay looking at urinary tumor DNA. This is a test which performs next-gen sequencing of 60 high-impact genes, including FGFR3, which is relevant, which we'll talk about. And they put it into their algorithm to give you a score from 0 to 100. And they represent a percentile rank of disease burden as per their test. And in their validation study, again, good sensitivity and specificity, as well as negative predictive value across the board. Interesting thing is it will graph it longitudinally over time here. And you can see that your relative UroAmp score can decrease or increase depending on the treatments or if you have a recurrence. And so it lets you kind of look at your disease process on a graph. Now, as I had alluded to previously, this is a study by Bladder in 2025 in which 135 samples were analyzed across patients who were having BCG for high-risk disease. They were all analyzed by UroAmp, and classified as either positive or negative. And what they found is that patients who were labeled positive at your baseline BCG had a significantly worse recurrence-free survival at 12 months, as well as patients who were positive at both your BCG, your 6 installation, or at your follow-up cysto, compared to those who were negative at both time points. 6 out of the 10 patients who were positive still post-BCG had a recurrence within 18 months, and the median lead time was just 5.6 months, suggesting that if you have a positive UroAmp, or if your urinary tumor DNA suggests that you're still positive despite your BCG, or even before you start BCG, your risk of recurring or being treatment unresponsive is actually significantly higher. This is another thing that's quite new, but erdafitinib, we know, is an oral therapy, which is a selective tyrosine kinase inhibitor that targets FGFR, approved in the locally advanced or metastatic setting for patients with the susceptible FGFR3 alterations. But they've recently developed this new device called TAR-210, which is an intravesical device that delivers erdafitinib over time across 90 days to treat the non-muscle invasive setting. And they showed in their first in-human study with patients with the alteration that intermediate risk NMIBC had a complete response at 1 year of 87%. And so here's a sort of hypothetical. You could have a patient who walks into your office. You start off with a UroAmp or a UTDNA test. It tests positive. So you say, I would like to do a cystoscopy because it's probably going to be positive. You do the cysto, you find a high-grade appearing tumor. You resect it, you get the pathology back, it necessitates BCG. So you start BCG. But before you start your first BCG, you do a UTDNA test, and it's still positive. And so you tell the patient, your chance for actually failing BCG is quite a bit higher, but we also know that your FGFR3 alteration is present based on the same test, and therefore, after you fail BCG, we could then put you on this new therapy called TAR-210. And so all of that can be encapsulated in just this one urine test, potentially. So, in conclusion, there's no perfect test. Every test has its pros and cons, has its strengths and weaknesses. But cytology remains the mainstay of our in-house, relatively economic, useful, non-invasive test, especially in the sense of it having a very high specificity. So in cases where your cystoscopy findings are negative, your imaging is negative, but you have a persistently positive cytology, it should cue you into occult disease somewhere. A few other categories of tests that we've described include Eurovision or the single protein monoclonal antibody test, which are interesting in theory, but not necessarily practice changing based on their relatively not impressive test characteristics. What is more relevant these days is the advent of genetic and epigenetic tests, which have quite promising evidence in both the detection and surveillance settings. There is some preliminary evidence in the interventional setting that you could decrease your need for cystoscopy safely, but again, relatively lacking in further prospective trials and needing further validation. And then on the up and up is the area of urinary tumor DNA, which is still emerging, but there may be use cases that go beyond simply diagnosis or surveillance of bladder cancer. So it remains to be seen where that field goes. Thank you.